Hi, I'm Dr. Farah Kamangar, and welcome to the Future of Dermatology podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
Good morning, everyone. Today we will be talking about acute and chronic radiation dermatitis. The impetus for this talk was the number of female patients who come in for routine skin checks that end up having a lot of questions years after their radiation is over, whether that be about just mottled pigment, telangiectasia, seborrheic keratoses. So we're just going to dive right into it. So radiation dermatitis is one of the most common side effects experienced by patients undergoing radiation therapy. It actually affects up to 95% of patients receiving treatment, making it a critical concern in oncologic and dermatologic care. Essentially, it's an inflammatory reaction of the skin occurring as a direct result of radiation exposure during cancer treatment. So think of it as a predictable but totally manageable skin injury that we need to anticipate and address proactively.
Can you move over a little bit because we can't see the screen? I'm sorry.
Once you look at the prevalence of radiation dermatitis, you see that it's a particular concern in certain cancer types. Breast cancer patients are most frequently affected, with up to 95% experiencing some degree of skin reaction. Head and neck cancer patients follow closely behind at about 85%. The risk and severity of radiation dermatitis correlate directly with the total radiation dose, the size of the treated area, and various species-specific factors that we will discuss shortly. Understanding risk factors is crucial for identifying high-risk patients and implementing preventative strategies early. Some patients are inherently more susceptible due to genetic factors, particularly those with mutations in the ATM gene. We also see increased risk in patients receiving concurrent chemotherapy, smokers, and those with comorbidities like diabetes. Age plays a role too, with older patients often showing increased sensitivity to radiation dermatitis. It's important to distinguish between factors that we can and cannot modify. While we can't change a patient's genetic predisposition or age, we can address viable factors like smoking status, weight management, and blood sugar control. This distinction helps us focus our interventions where they will be most effective. For example, weight loss before starting radiation therapy has been shown to significantly improve tissue healing and reduce complication rates. As dermatologists, it's especially important for us to know that the use of sunscreen after radiation therapy can help prevent some of the skin changes associated with chronic radiation dermatitis. Briefly, let's examine why the skin is particularly vulnerable to radiation damage. The most radiosensitive cells in the skin are the basal keratinocytes, melanocytes, and hair follicle stem cells. These cells have high mitotic rates, making them especially susceptible to radiation-induced DNA damage. Understanding the cellular sensitivity helps explain the clinical manifestations that we observe, whether it's erythema or hair loss. The process of radiation damage occurs in multiple phases. Initially, we see direct DNA damage and free radical formation within minutes of exposure. This triggers a cascade of inflammatory events leading to vascular changes and tissue ischemia. What's particularly important to note is that this damage is cumulative. Each fraction of radiation builds upon previous damage, which explains why symptoms typically worsen as treatment progresses. TGF-beta plays a central role in the development of radiation-induced skin changes, particularly in chronic cases. This cytokine is the master regulator of fibrosis, stimulating collagen production and promoting differentiation of fibroblasts into myofibroblasts. Understanding this pathway is crucial because it represents a potential therapeutic target. The acute inflammatory response begins within hours of radiation exposure. We see rapid influx of pro-inflammatory cytokines, and this leads to the classic signs of inflammation, erythema, warmth, and anemia. The severity of this response can often predict the likelihood of developing more serious reactions, making early assessment crucial. Briefly, RTOG, radiation therapy oncology scoring criteria, is a set of widely used criteria for grading the severity of radiation-induced toxicity. I won't go over these in detail, but basically grade 0 is normal skin, what we would see at the start of treatment. Grade 1 is faint or dull erythema with follicular darkening. Grade 2, bright pink skin, a lot of feeling like a sunburn. Grade 3, deep red or dark colored skin with moist feeling of folds, often pain requiring medication. And deep 4, deep breakdown of skin, bleeding from minor trauma, usually requiring somewhat immediate medical attention. Acute radiation dermatitis, by definition, occurs within 90 days of starting treatment. The timeline is fairly predictable. Initial symptoms typically appear within 1 to 4 weeks of starting radiation, peak at about 1 to 2 weeks after completing treatment, and usually resolve 2 to 4 weeks post-therapy. The progression of radiation dermatitis follows a very characteristic pattern. In weeks 1 to 2, patients typically experience mild erythema and possibly mild pruritus. By weeks 2 to 3, we often see moderate erythema and dry desquamation. The most severe reactions, including a white desquamation, typically occur after brief. Desquamation represents a very significant turning point in radiation dermatitis. We categorize it into dry and moist. Dry desquamation presents as flaking and peeling, while moist desquamation is obviously far more severe, involving loss of the epidermis and exposure of the dermis. When we start to see moist desquamation, it is crucial to modify our management approach to prevent infection. Pigmentary changes are nearly universal in radiation dermatitis. The initial erythema results from vasodilation and increased permeability of dermal vessels. As treatment progresses, we often see hyperpigmentation due to melanocyte stimulation. What's important to note is that while erythema typically resolves within months, pigmentary changes can persist much longer and may even be permanent in some cases. Hair loss in the treatment field typically begins 2 to 3 weeks after starting radiation. The radiosensitivity of hair follicle stem cells means that doses exceeding 50 gray, the hair loss often is permanent. Concurrent edema results from increased vascular permeability and compromised lymphatic drainage. It is important to note that as regimens involving increasing hypofractionation of radiation therapy do become far more common, rates and severity of acute radiation dermatitis, they eventually become lower as acute skin reactions are less sensitive to fraction size. Moving into chronic radiation dermatitis, we're now looking at changes occurring beyond 90 days of treatment. These changes can develop months to years after radiation therapy, and importantly, they may progress over time. What makes this particularly challenging is that there is often a latent period where the skin appears to have healed, giving patients a very false sense of security. It is also important to note that there is currently a very limited understanding of which patients will go on to develop the different manifestations of chronic radiation dermatitis, when they will develop these symptoms, and how severe their presentation will be. This contrasts with acute radiation dermatitis, in which the time sequence symptom development is very well understood. Dermal fibrosis is perhaps the most significant chronic change we see. It is characterized by excessive collagen deposition and results from sustained activation of TGF-beta signaling. This leads to progressive hardening and decreased elasticity of the skin. The clinical impact could be quite significant, potentially even causing restricted movement and contractures. Chronic pigmentary changes differ from acute changes in their persistence and their pattern. We often see a mix of hyperpigmentation and hypopigmentation, creating a very mottled appearance to the skin. These changes tend to be far more pronounced in patients with darker skin types. Sun protection becomes crucial as these areas remain very susceptible to UV damage and further pigmentary alteration. Telangiectasias typically appear 6 to 12 months post-radiation and continue to develop over years. These dilated blood vessels result from damage to the dermal vasculature and can be particularly distressing for patients due to their cosmetic appearance. While primarily a cosmetic concern, they can occasionally cause bleeding, and they typically require specific management approaches such as this. An important but often overlooked aspect of radiation therapy is the long-term development of skin lesions in the treatment field. Let me briefly address 2 key types of lesions you commonly see. First, there's an increased risk of squamous cell carcinoma in previously irradiated skin. These typically present as rapidly growing, sometimes painful lesions that bleed and do not heal on their own. More commonly and quite reassuringly, we see an increased development of seborrheic keratoses, what I often like to call radiation barnacles. These benign growths can look quite dramatic and often cause significant anxiety for patients who may mistake them for melanoma. They appear as stuck on waxy or scaly papules or plaques and are, of course, completely harmless, as we know. This information should be part of our long-term follow-up discussions with patients receiving radiation therapy. Radiation-induced skin atrophy is a progressive condition characterized by thinning of both the dermis and the epidermis. The loss of skin appendages, including sebaceous glands and hair follicles, makes this tissue particularly vulnerable to trauma. What's crucial for clinicians to understand is that atrophic skin has significantly impaired healing capacity and requires special consideration in any upcoming procedures. The use of topical corticosteroids requires careful consideration. Class 1 steroids have shown the most benefit when used appropriately. Early intervention is key. We typically start at the first signs of grade 2 radiation dermatitis. As increased severity of acute radiation dermatitis may be associated with increased risk of chronic radiation dermatitis, methods to prevent acute manifestations can help prevent the changes associated with chronic radiation dermatitis. While various topical agents have been studied, the evidence for many is really quite limited. Hyaluronic acid shows promise in some studies, and calendula has demonstrated some mild benefit in breast cancer patients. However, we must be very transparent about the mixed results of these clinical trials. Cost considerations are also very important, as many of these products are not covered by insurance. This is a crucial point that often surprises both patients and clinicians. Traditional antihistamines are ineffective for radiation-induced pruritus. The mechanism of radiation-induced itching differs fundamentally from allergic pruritus. While oral antihistamines might provide some benefit through their sedating properties, our focus should be on maintaining skin barrier function and using targeted anti-inflammatory treatments. Briefly, while most radiation dermatitis follows a very predictable course, it's crucial to be aware of a few rare complications. EPPR, which stands for eosinophilic polymorphic and pruritic eruption following radiotherapy, is a distinctive entity that we need to recognize. It typically affects breast cancer patients and can occur weeks to months after treatment completion. Interestingly, the eruption often extends well beyond the radiation field, which can make diagnosis very challenging if you're not familiar with this condition. A clinical presentation of EPPR is very distinctive. Patients develop intensely pruritic papules and plaques that can extend beyond that radiation field. The histology shows a characteristic eosinophilic infiltrant. What's particularly challenging is that it can mimic other conditions such as drug reactions or even viral exanthems. A careful history and recognition of the temporal relationship to radiation therapy is crucial for diagnosis. Understanding the natural history of EPPR is important for patient counseling. This condition typically is self-limiting, lasting 2 to 6 months, though the course can be really quite variable. Treatment response to topical steroids is not always predictable, and some cases may require systemic therapy. Unfortunately, we don't yet have reliable prevention strategies, making early recognition and appropriate management crucial.
Sure. How soon after radiation is that occurring?
Years.
Okay.
So that makes it easy. Years, and it looks really, really pretty impressive. They actually used a couple, they've done Dupixent a few times, which is cool. We say have something to pick it up for the patients aside from prednisone. Post-irradiation morphia is another very rare but significant complication. I've actually had 2 of these cases in the last few years, which was good for my learning. What makes this condition particularly challenging is its very delayed onset. It can begin months, but usually more likely years after treatment is completed. While it typically begins within the radiation field, that it could extend well beyond these boundaries, making it a dynamic and potentially progressive condition. The clinical course of post-irradiation morphia is biphasic. It begins with an inflammatory phase characterized by erythema, followed by progressive induration and fibrosis. Pain and restricted movement are common complaints. Treatment requires a very multimodal approach, combining topical or intralesional steroids, systemic immunosuppression when necessary, and even physical therapy to maintain range of motion. Long-term monitoring is essential due to the progressive nature of this condition. So as we conclude, let me emphasize several points. First, prevention and early intervention are paramount in managing radiation dermatitis. Second, regular monitoring during treatment allows for timely interventions. Third, risk assessment must be individualized, considering both patient and treatment factors. And finally, success depends heavily on patient education. This is a team effort involving radiation oncology, dermatology, and most importantly, the patient. Thank you.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.